Hello guys, welcome to my channel. In this video, I am going to discuss about the peritonsilar abscess. It is otherwise called Quinsy. It is the most repeated university question and also frequently in university practical examination they ask. Okay, in previous video, I am discussed about the acute tonsillitis and chronic tonsillitis. Before enter into the proper topic, the objectives are we are going to see about the etiology, clinical features, and examination and investigation, how to treat the peritonsillar abscess, and what are the complications. Before enter into the peritonsillar abscess, we have to know the anatomy. Previously, I am told in acute tonsillitis, I told about the anatomy. Here, I'm just tell about the capsule, and this is a superior constrictor muscle. See, the pink one is superior constrictor muscle, and this is the capsule of the tonsil. The space between the capsule and the superior constrictor muscle, that is called peritonsillar space. So accumulation of the pus between these two is peritonsillar abscess. Here it is the collection of pus in the peritonsillar space which lies between the capsule of tonsil and superior constrictor muscle. In coming to the etiology, the most common organism is Streptococcus pyogenes and Streptococcus aureus and are anaerobic organism. You have to remember these two, Streptococcus pyogenesis and Streptococcus aureus. First, peritonsillar abscess usually follows acute tonsillitis first. One of the tonsillar crypts we already seen in anatomy, there is a one crypta magna gets infected and sealed off. It forms an intratonsillar abscess which then bursts through tonsillar capsule to set up a peritonsillitis and then an abscess. First, the patient had acute tonsillitis and the pus filled in the crypta magna and then burst leads to peritonsillitis formation and leads to abscess. And coming to the clinical features, how the patient presented with complaints. In peritonsillar abscess, mostly it affects the adults. Usually it is unilateral, occasionally it is bilateral. Clinical features are divided into two. One is general, other one is local. First, what is general? They are due to septicemia, the patient look like toxic and resembles any acute infection. They include fever, chills, rigors. The fever, chills, rigors, we have to think about any infection, any bacterial infection. And patient presented with general malaise, body ache, headache, nausea, and constipation. And the local features are patient have a severe pain in throat and odynophagia. Odynophagia means difficulty in swallowing. Muffled and thick speech, often called hot potato voice. The hot potato voice is repeatedly asked in MCQ and also Viva question also. And foul breath due to sepsis. And ipsilateral earache. Referred pain via ninth, that is glossopharyngeal nerve, which supplies both tonsil and the ear. And trismus. Trismus is due to spasm of the pterygoid muscles which are in the close proximity to the superior constrictor. Trismus means not able to open their mouth. These are all the local features. Severe pain, odynophagia, hot potato voice, foul breath, and referred pain and trismus. How to examine this patient? The tonsil pilus soft pellet on involved side are congested and swollen. Tonsil itself may not appear enlarged as it gets buried in the edematous pillar. In this tonsil is buried in the between the two pillars. Uvula is maybe swollen and edematous and pushed to the opposite side. If the person peritonsillar abscess present in the right side means the uvula is deviated to the left side, and bulging of the soft palate anterior pillar above the tonsil. Here finally, first tonsil, pillar, soft palate, uvula, these are all congested and swollen. If it is tonsil means tonsil buried between the two pillars. Uvula means it is deviated to the opposite side. Here you can clearly see here the quinsy is present in the left side. Here it is deviated to the uvula is deviated to the right side. And mucopus may be seen covering the tonsillar region and cervical lymph node involved. The main cervical node is jugulodigastric node and torticollis. Torticollis means patient keeps the neck tilted to the side of the abscess. For example, this is the patient. He had a right side quinsy. He turned the neck in right side only. And coming to investigation. First, we are take CT, contrast enhanced CT, CECT or MRI, show the abscess and extent. And needle aspiration of an abscess provides material for culture and sensitivity. First, CT, MRI. We have to know where the pus is extent, and take the needle aspiration and send it to the microbiology department for culture sensitivity. Then only we know which organism is the cause of this quinsy. And the treatment. How to treat? We have to hospitalize the patient and intravenous fluid to combat dehydration, because they are not able, due to odynophagia and severe pain in the throat, so the patient can't able to take food. That's why we have to hydrate the patient and give antibiotics and analgesics like paracetamol. For relief pain, aspirin is avoided because it is danger of the bleeding. And oral hygiene should be maintained. Maybe the peritonsillar abscess came from any dental caries. That's why we have to maintain the oral hygiene. And how to surgically, how to treat? First, incision and drain. First, incise the peritonsillar abscess and then drain the pus. A peritonsillar abscess is opened at the point of maximum bulge above the upper pole of the tonsil or just lateral to the point of the junction of the anterior pillar within a line drawn through the base of the uvula. And with the help of the guarded knife, a small stab incision is made and then we drain the pus. Here you can clearly see we made it two incision, one horizontal incision and another one is vertical incision. Vertical incision along the upper pole of the tonsil and horizontal incision is through the base of the uvula. We are just the site of the drainage is lateral to the junction. This is the junction, lateral to the junction of the vertical line through the anterior pillar and horizontal line through the base of this uvula. So we have to drain lateral to that junction. Then the sinus forceps is inserted to open the abscess. Putting the sinus forceps, the following they may also be necessary to drain any reaccumulation. And if it is accumulate again, we have to drain it. And interval tonsillectomy we can do. Tonsils are removed 4 to 6 weeks after the attack of quinsy. that is interval tonsillectomy. Because first the patient presented with quinsy and then tonsil is removed. Abscess or hot tonsillectomy. Some people prefer don't do hot tonsillectomy instead of incision and drainage. And complication. If we don't treat that acute peritonsilar abscess, what will happen? That is parapharyngeal abscess. That means the abscess spread to parapharyngeal space and form the parapharyngeal abscess. And edema of the larynx due to tracheostomy. If we do any tracheostomy while doing this procedure, it leads to edema of the larynx and septicemia like endocarditis, nephritis, and pneumonitis lung abscess due to aspiration of the pulse, and jugular vein thrombosis and spontaneous hemorrhage. Thank you. Subscribe to my channel, share to your friends.